Hi, this is Corinne Del Rosario, one of the urology nurse practitioners at the UCLA Health Department of Urology. I want to thank the Society of Urologic Nurses and Associates for the opportunity to present our work. This is the predictive value of voiding efficiency after active void trial in men undergoing BPH surgery. We report no financial disclosures. The timing of the Foley catheter removal after a transurethral resection of the prostate, or TURP, or holmium enucleation of the prostate, HOLEP, has been debated. On the one end, early Foley catheter removal reduces the patient's discomfort and catheter-associated infections. However, this management strategy may place patients at risk for urinary retention, which has been reported to occur in 10 to 15% of patients after BPH surgery. The objectives of our study was to assess the reliability of voiding efficiency of the first void after active filling compared to subsequent voids, to assess the independent association between voiding efficiency and urinary retention after discharge, to determine if any other perioperative clinical factors are associated with urinary retention after discharge. This is an ongoing prospective cohort study, which is an observation of clinical practice from December 2019 to August 2021. All men included in the study underwent TURP or HOLEP, and all underwent a trial of void on postoperative day 1. Patients whose Foley catheter was reinserted prior to leaving the hospital were excluded. The main exposure is the percentage of bladder emptied after active void trial by the nurse practitioner and residents. Normal saline instilled in the bladder until a strong urge of void and Foley catheter was removed. Patients were categorized into 3 groups: those who emptied less than 50%, 51 to 75%, and those who emptied 75% of their bladder. We had about 188 patients. The median age was 70. Median prostate was about 100 grams. 78 patients underwent TURP and 110 underwent HOLEP. 13 of these patients had previous BPH surgery. 79% were voiding spontaneously prior to surgery, and 19% required Foley or CIC after discharge. This table shows the voiding characteristics of the cohort. The median voiding efficiency for the active void trial was 75%. On the average, the voiding efficiency decreased with subsequent voids. This figure shows the proportion of patients presenting for urinary retention after discharge, stratified by voiding efficiency and prostate size. 40% of patients with prostate size smaller than 80 grams and a voiding efficiency of less than 50% presented for urinary retention after discharge. Conversely, 0 patients presented for urinary retention after discharge with a prostate size greater than 80 grams and a voiding efficiency greater than 75%. In conclusion, the initial void does not strongly correlate with the ability to one's bladder on subsequent voids. The initial void does not strongly correlate with the ability to empty one's bladder on subsequent voids. Patients who emptied less than 50% of their bladder on post-op day 1 have a smaller preoperative prostate and have a smaller preoperative size prostates are high risk for urinary retention. Clinicians should consider replacing the Foley catheter in these group to avoid urinary retention after discharge. I would like to acknowledge my co-authors and thank you for your time.